A 55-year-old man walks into a clinic feeling confident about his health. He is not overweight, his blood pressure is within normal range, and he maintains what he believes is a relatively healthy lifestyle. There are no obvious warning signs, no chest pain, no fatigue beyond what he considers normal, no limitations in his daily routine. However, his physician recommended a coronary calcium scan due to a family history of heart disease and the recent sudden death of a colleague. The results come back positive. Significant calcium deposits are found within his coronary arteries. Despite feeling well, he is now faced with a diagnosis that suggests advanced atherosclerotic changes. Understandably, he is concerned and asks the most important question: what should I do now? This scenario is increasingly common in modern clinical practice. Many individuals who appear metabolically healthy on the surface, normal weight, acceptable blood pressure, even standard lab values, are found to have underlying cardiovascular disease. Coronary artery calcium, CAC scoring, has become a powerful tool for detecting subclinical atherosclerosis. Studies such as those published in the Journal of the American College of Cardiology have shown that CAC scoring significantly improves cardiovascular risk prediction beyond traditional markers, Budoff et al., 2018. But identifying the problem is only the first step. The deeper question remains: why is this happening in seemingly healthy individuals? If you're finding this kind of deep, science-backed health breakdown helpful, make sure to subscribe to the channel so you don't miss future insights that could genuinely change how you approach your health. At first glance, the typical metabolic culprits may not be present. Insulin levels may be normal. Hemoglobin A1C may fall within a healthy range. There may be no obvious signs of metabolic syndrome. Yet the presence of coronary calcium indicates that a long-standing inflammatory process has been active within the arterial walls. Atherosclerosis is no longer viewed simply as a cholesterol storage disease. It is now widely recognized as a chronic inflammatory condition. Libby 2021, Nature Reviews Cardiology. This shifts the clinical investigation toward uncovering hidden sources of inflammation. One such source that is gaining increasing attention in medical research is the liver. When an ultrasound reveals fatty infiltration of the liver, known as non-alcoholic fatty liver disease, NAFLD, it raises critical questions. NAFLD affects approximately 25% of the global population and is strongly associated with cardiovascular disease, even independent of traditional risk factors. Unasi et al., 2016. The presence of fatty liver in someone with normal insulin levels challenges the conventional assumption that insulin resistance is always the primary driver. If insulin resistance is ruled out, other causes must be considered. Alcohol consumption is a common factor, but in this case, the patient does not drink. Excessive intake of certain nutrients, such as branched-chain amino acids, BCAAs, has been linked to metabolic disturbances and liver fat accumulation, Newgard et al. 2009. But again, this does not apply here. Viral hepatitis is another possibility, yet laboratory tests come back negative. At this point, the investigation must go deeper, into the gut. The gut-liver axis is one of the most critical and complex relationships in human physiology. Everything absorbed from the intestines is transported directly to the liver through the portal vein. This means the liver acts as a first-line processing center for nutrients, toxins, and microbial byproducts. The intestinal barrier plays a crucial role in determining what enters this system. Under normal conditions, this barrier is highly selective, allowing nutrients through while blocking harmful substances. This barrier is composed of several layers of defense. The mucin layer acts as a physical shield, preventing direct contact between gut bacteria and the intestinal lining. Tight junctions between intestinal cells regulate permeability, ensuring that only appropriate molecules pass through. Additionally, the gut-associated lymphoid tissue, GALT, including Peyer's patches, serves as an immune surveillance system. Together, these components maintain a delicate balance. However, when this system is compromised, a condition often referred to as increased intestinal permeability or leaky gut can occur. While once controversial, this concept is now supported by growing scientific evidence. Research has shown that disruption of tight junction proteins can allow bacterial components, such as lipopolysaccharides, LPS, to enter the bloodstream. Fasano, 2012. This phenomenon is known as metabolic endotoxemia. LPS, a component of the outer membrane of gram-negative bacteria, is highly inflammatory. And when it enters circulation, it triggers immune activation and systemic inflammation. Studies have demonstrated that even low-grade elevations in LPS can contribute to insulin resistance, liver inflammation, and atherosclerosis. Connie et al.'s 2007 Diabetes. In the liver, LPS stimulates inflammatory pathways that promote fat accumulation and fibrosis. But the effects do not stop there. LPS also interacts with lipoproteins, particularly low-density lipoprotein, LDL. Under inflammatory conditions, LDL particles can become oxidized and smaller in size, forming what are known as small dense LDL particles. These are more atherogenic, meaning they are more likely to penetrate the arterial wall and contribute to plaque formation. Austin et al., 1988. Within the arterial wall, when immune cells such as macrophages engulf these modified LDL particles, becoming foam cells. Over time, these foam cells accumulate, forming fatty streaks that evolve into atherosclerotic plaques. When inflammation persists, these plaques can become unstable. Unlike calcified plaques, which are generally more stable, soft plaques are prone to rupture. When rupture occurs, it can trigger the formation of a blood clot, leading to a heart attack. This process highlights a critical concept. Atherosclerosis is not merely about cholesterol levels. It is about inflammation and immune response. The arterial plaque can be thought of as a reverse pimple, building up beneath the surface until it eventually ruptures. This analogy underscores the dynamic and potentially dangerous nature of the disease. Given this understanding, the question becomes, how do we address the root cause? If metabolic endotoxemia driven by gut dysfunction is contributing to both fatty liver and coronary artery disease, then treatment must focus on restoring gut integrity and reducing inflammation. One important step is identifying food sensitivities. While gluten often receives the most attention, wheat contains hundreds of proteins, many of which can trigger immune responses. Food sensitivities to dairy, corn, eggs, and other common foods can also contribute to intestinal inflammation. Elimination diets and testing can help identify these triggers. Another key factor is the composition of the gut microbiota. An imbalance in gut bacteria, known as dysbiosis, can lead to reduced mucin production and weakened barrier function. In some cases, this imbalance manifests as small intestinal bacterial overgrowth, SIBO. SIBO is characterized by excessive bacteria in the small intestine, where they ferment carbohydrates and produce gases such as hydrogen and methane. Hydrogen breath testing is commonly used to diagnose SIBO. A rise of more than 20 parts per million in hydrogen levels after consuming a carbohydrate solution suggests bacterial overgrowth. Symptoms often include bloating, gas, and discomfort after eating carbohydrates. Treating SIBO typically involves a combination of antimicrobial therapies, dietary changes, and targeted supplementation. Diet plays a central role in shaping the gut microbiome. Fiber, particularly soluble fiber, is essential for feeding beneficial bacteria. Unlike insoluble fiber, which adds bulk to stool, soluble fiber is fermented by gut bacteria into short-chain fatty acids, SCFAs, such as butyrate. SCFAs have anti-inflammatory properties and support the integrity of the intestinal barrier. Coe et al., 2016. Interestingly, the way food is prepared can influence its impact on gut health. For example, cooling cooked starches like rice or potatoes increases their resistant starch content. Resistant starch is not digested in the small intestine and instead serves as a prebiotic, feeding beneficial bacteria in the colon. Fasting also emerges as a powerful tool in this context. Time-restricted feeding, such as an 18-6 fasting schedule, allows the gut to rest and repair. During fasting periods, the absence of incoming food reduces bacterial fermentation and may help rebalance the microbiome. Additionally, fasting has been shown to reduce inflammation and improve metabolic markers. Longo and Panda, 2016, cell metabolism. Another important consideration is the avoidance of processed foods. Many processed foods contain emulsifiers, additives that improve texture and shelf life. However, research has shown that certain emulsifiers can disrupt the gut microbiota and promote inflammation. Shassing et al., 2015, Nature. Similarly, artificial sweeteners and food additives can negatively impact gut health. The connection between the gut and the brain adds another layer of complexity. The gut is often referred to as the second brain due to its extensive network of neurons, known as the enteric nervous system. Signals from the gut can influence mood, cognition, and behavior through the gut-brain axis. Inflammation originating in the gut has been linked to conditions such as depression and cognitive impairment. Cryan and Dinan, 2012. Addressing gut health, therefore, has far-reaching implications. Improvements in gut integrity and microbiome balance can lead to better liver function, reduced cardiovascular risk, and even enhanced mental well-being. This holistic approach represents a shift from symptom management to root cause medicine. In managing a patient with coronary artery calcium and fatty liver, the strategy becomes clear. Identify and eliminate inflammatory triggers. Restore gut integrity through diet, fiber, and targeted therapies. Use fasting strategically to promote healing. Monitor progress with appropriate testing and adjust the approach as needed. This is not a quick fix. It requires commitment, consistency, and a willingness to look beyond conventional markers. But the potential rewards are significant, not just in preventing disease progression, but in improving overall health and quality of life. If you want more in-depth, research-backed explanations like this, and practical strategies you can actually apply, make sure to subscribe and stay connected. Your health decisions today can shape your future in ways you may not yet realize.